Our next patient is Grace, who's in her early 40s, who on the MERS hand grading scale is in number 2, where you can see a moderate depletion of the volume and a very mild prominence of the tendons and some veins. So in this particular case, what I like to use is calcium hydroxyapatite, but at a different concentration and a different volume. And here I take 0.8 cc's of calcium hydroxyapatite and mix it with 0.8 cc's of 1% lidocaine for a total of 1.6 cc's, and we will be injecting each hand with a total volume of 1.6 cc's. And again, what this points out is that depending on the severity and the grading of each patient's depletion of the volume of the hand, you can adjust it based on the grading scale and use the grading scale to your advantage and ultimately to the patient's benefit. The first thing that I do is, of course, I mark the access point using the 22 gauge 50 millimeter cannula. It's a proximal injection and along the distribution of the tendons, making sure that I reach the MCP joint. Once I mark the area, I infiltrate it with 1% lidocaine, little pinch, 1% lidocaine with epinephrine of 1 to 200,000. Just raising a little bit of a bleb, and what that does, it just separates the tissue. The plane that we want to enter is between the dermis, the deep dermis, and the superficial fascia. And what I do is make an access point utilizing a 21 gauge needle. I tent the skin up to separate it from the underlying structures. Just a little puncture going through the dermis, right into that superficial fascia. Recently, anatomically, that fascia was described as a very sort of sponge-like material that expands upon infiltration with a filler. And when you look at it clinically, that's absolutely true, because it's really more a three-dimensional expansion versus a two-dimensional filling. Now we just enter that space. Just lift up your hand a little bit and just bend it. Here we go. And you can see the cannula on the undersurface of the dermis. It's a retrograde infusion, so to speak, from distal to proximal. Again, a total infiltration of 1.6 cc's. This is being customized based on each patient's specific anatomy and requirements. I use a number of different fillers in my injection of the dorsum of the hands: calcium hydroxyapatite, hyaluronic acid, PLLA, and once in a while, patient's own fat. Just make a fist, please. And now, even though it's evenly distributed, what I want to do is get it a little bit softer and more evenly distributed. I use Aquaphor just to make sure that the massage is even. There's no extra charge for the massage. But the reason to use in this particular case the 0.8 cc syringe of calcium hydroxyapatite is that at grade 2 she doesn't really need a tremendous amount of volume, so I think it makes more sense to use 0.8 cc of calcium hydroxyapatite per side, see the patient in 4 to 6 weeks, and if necessary, to inject more. I doubt very much that another injection will be necessary, because I think we're getting a very nice improvement already. Straighten out your hand, please. What I do is I always check both when the hand is flexed and open. Also notice that with cannula infusion, there's really very small possibility of ecchymosis black and blue, because you saw that the veins, the dorsal veins, are just sort of displaced away from the blunt tip of the cannula and not pierced, as sometimes can happen when you're utilizing a needle. Make a fist again, please. And even the dilution in this particular case, it's an off-label use because the dilution is higher than that on label. Straighten out. Again, it's a nice even distribution. What we'll do is move over to the right side and do exactly the same thing.